in treating the younger kids?
Yes. So it mostly happens in younger generation only. Those patients having a strong immune response. See try to understand the pathology. This happens when the patient strongly reacts to the antigen. That means they have a strong immune response. Mostly happens in younger individual. Normally what happens, we are exposed to the environmental fungi. That is, fungus is ubiquitous in the environment. And we also are exposed, we also inhale, but our mucociliary activity, whatever fungus we inhale, take back to the nasopharynx and then to the gut and out. If this fungus happens to get trapped somewhere and the person is allergic to that fungus, the immediate eosinophilic reaction will trap the fungus. And that's how the irreversible phenomena or vicious cycle starts. Once it happens to get trapped in the sinuses. Mostly you'll see such patients are young, unilateral disease, and the goal is the fungus, whatever is trapped around with the eosinophilic response is there, that fungus acts as an antigen. So first you need to remove that fungus, widen the sinuses. The moment you remove the fungus and the eosinophilic reaction, your inflammatory load will come down and then follow with the steroid therapy. Steroid is the mainstay of AFRS treatment. And to switch from oral to topical, you need a sinus surgery. That will allow, or that can allow the topical to reach inside. So the surgery has a role of switch over from oral to topicals, as the topicals now will penetrate without opening the sinuses, the topicals will not enter inside. So steroid is the only answer. Then we follow these patients later on with a skin prick allergic test to the various fungal antigens. If we find then immunotherapy, sometimes it is effective, sometimes not, but the long-term steroid therapy is the answer.
Sir, what is your regime pre-operatively and post-operatively oral steroids for kids?
For this kind of disease,
AFRS.
AFRS is 1 milligram per kg. AFRS is requires high dose steroids to begin with. AFRS is all steroid dependent disease. Though it is fungal, but there is no role of antifungals. It is the reaction of the body to the fungal antigen which creates problem. It is the fungus which is not invading, giving problem.
Thank you, sir.
Satish, is there any role of these monoclonal antibodies, ZUMABs, in treatment of CRS with polyps?
Yes. In selected cases, again, the role of monoclonal antibodies is to work at the molecular level to block the CRS cascade. Let me tell you, CRS is a disease which has been identified, as I told you, at a molecular level, and the entire cascade has been, identified. Now, there are targets defined at the molecular level, and for those targets, the monoclonal antibodies have developed to arrest the inflammatory process at the molecular level even before the clinical manifestation develops. So that is the future. Now the issue is the safety and long-term results, and that's how a lot of studies are undergoing. Still, these being used in various situations, in very extreme situations, in severe asthmatics, this kind of therapy is being used. Let me tell you in brief, in 2 minutes, how the monoclonal antibodies works and what is the rationale behind that. Can you connect to laptop? See now, as I told you, this is an immune complex disease. Our sinonasal epithelium is the first line immune barrier. In order to give CRS, this immune barrier has to be crossed by the environmental allergen, microorganism, whatever challenge coming to it. And see, there are three systems to protect or by the sinonasal immunity. One is this intact epithelium. This intact epithelium with the junctions prevent anything to penetrate into the mucosa. Second thing, anything coming onto the surface is expelled by the mucociliary system. And third is, by this cilia, a lot of antimicrobial proteins are secreted, more than 1,000 times of protein, enzyme, opsonin, so many things. So whatever environmental toxin, allergen, microorganism come to the surface are taken by this, this immune system. These three to protect for the mucosa to breach. And once it is breached, suppose, then there are certain pattern recognition receptors are there on the mucosa. They recognize the challenge and then the adaptive immunity comes into action. So, see now these are the variety of, proteins, immune molecules secreted by the mucosa to tackle lots of challenges coming to the nasal surface. Now, what happens? When the pattern recognition receptors, they sense something which is invading the mucosa, some challenge, maybe microbiota, maybe allergen, maybe protein, whatever. See, once this pattern recognition receptors are, they sense the antigen attached to the receptor, then these liposomal proteins, interleukin 25, 23, 33, they are secreted and they activate the innate lymphoid cells too, type 2 cells, which activates the T lymphocytes. And T lymphocytes are then the response of the T lymphocyte is deviated towards the T helper 2 cells by the interleukin 4. See, these are the mediators. I am coming to why I am telling you all this. I'll come to it. That's a normal pathway. So interleukin 4 will stimulate the TS2 lymphocytes, and TS2 lymphocytes is the hallmark of the entire disease, eosinophilic disease. This will secrete interleukin 5 to stimulate the eosinophils. This will stimulate further secrete interleukin 4 and 13 to act on the bronchial muscles, to secrete interleukin 4 and 13 to stimulate the B cell, to stimulate IgE production, to stimulate the basophilic production, and all these eosinophil, basophil, they go on to the submucosal surface and give a lot of damage to the submucosa and the mucosa. This is the whole cascade which is identified now at the clinical level. Now, if this cascade, see this, if this pathway, once the pattern recognition receptors are stimulated, if this pathway of stimulating the thymic liposomal protein is blocked, let me tell you, if this pathway is blocked here, the further sequence will automatically stop. Then we have another target we have identified to block the interleukin 4 receptor. This has been identified, monoclonal antibody to block the interleukin 4 receptor. Then the interleukin 4 and 13 receptor can be blocked. Interleukin IgE receptor blockage, monoclonal antibody is available. Interleukin 5 receptor blockade antibody is available. So all these will block the further eosinophilic, IgE, basophilic response, which manifest as polyps and the ongoing CRS. So these are a lot of monoclonal antibodies developed, like anti-IgE, that is omalizumab, anti-IL-5 is mepolizumab, anti-IL-5 receptor antibodies, benralizumab, it is clinically available after the, the stage 3 trials. They are being extensively used in severe asthmaticus because upper and lower airway has the same, pathophysiology. And so they are being used, but not very extensively being used in sinusitis. Yes, in extensive disease, even a single shot will reduce the inflammatory byproducts level to minimum. And it gives amazing relief, but the long-term safety is still a question mark. Long-term remission is still a, question mark. And the cost is a limiting factor as they are damn costly. So there are a lot of other monoclonal antibodies are in system, in the research work being developed at a low cost, safer and more. So in future, this is going to be the treatment to block the CRS cascade at the molecular level before the clinical manifestation develops. So this is future. Now, what can be done in the present context? In the present context, at every level, what you have seen, at every level, The only thing which works is the steroid. So now what happens? What steroid you can give? You can't give oral steroid for longer. So what you can give, whatever disease you have, you can give the topical steroids. Oral steroid short courses to give remission and then follow with the topical steroids. And if it doesn't work, that's how we give indication for sinus surgery. If the conservative management, the maximal medical management, adequate medical management fails, then the role of sinus surgery. And what is adequate medical management? Topical steroid. In pre-operative setting, what topical steroid we can give? Only nasal sprays. The douching of the Budicort and all that will not penetrate deep into the sinuses unless you have opened the sinuses. So the only weapon of topical steroid, because systemic you cannot give because of the adverse effect, is the topical. So those patients who have a very little disease profile can be managed with a topical. Those who have extensive disease profile, the topical will not work. And then comes the role of sinus surgery. I have already told you the three-prong, target of sinus surgery to establish the ventilation drainage by removing, like we removed the inflammatory load today, and to provide access to the topical. This, in the present context, is the only weapon what we can have. Targeted therapy are underway, future, and this is going to be the future in the coming, decade or so. And if this therapy is established as a standard of care with more safer drugs, more, economically viable drugs, then the FES or sinus surgery will be less and less required. Because this is the only option right now us to do all this. It is not the final treatment. I hope you understand what I'm trying to say.
Yes, sir.
Yes, that's very good explanation. Satish, we have a problem with the topical steroids in Pakistan. This mometazine, and budesonide is available in Pakistan only in nasal sprays. It is not available as a powder form. It is not available as drops. It is not available.
See, sprays and irrigations are two different things.
Yeah, because we want to give irrigations. So for irrigation, we do not have any material available here. Apart from
you don't need. What you need to use is the budesonide respules, which are used by the physicians to nebulize for asthma.
Okay.
Those are the same respules which
They are quite expensive in Pakistan, actually.
I don't think the respules are so expensive. I don't know. But those are the same thing. You ask your physician colleague what respule they use for nebulization for asthma. Because that is the standard therapy for asthma management.
We also want to know the dose. What is the concentration and how you prepare it for? And do you use it high volume and low pressure douches?
Yes, high pressure, high volume.
High pressure.
Tell you. Let me tell you. Yes. See, this dynamics, to understand this dynamics, these are the variables you need to understand. Delivery technique, how will you ensure it reaches everywhere? The device, then the volume, pressure, position, like we discussed the position. Then more importantly, the surgical state of the cavity. If you have not given a full house FES, like with this, in this case, you have not given a wide openings, and you have a massive disease profile, your topical will not reach effectively and it is going to be a failure. So surgical state of the cavity is one of the most important determinant of the success of the topical therapy. What my point? So we should have a good surgical state of the cavity, allowing the topical to penetrate deeply into it. And see, these are the positions I told you. A lot of devices are available. We use just simple collapsible rubber bulb. That works very well. Now, what I'm trying to say, the surgical state of the cavity. See these three cavities. This cavity, if you try to douche, see this is again a full FES done. This will not allow the steroid to reach effectively into the sinuses. Can you see the narrow cavity?
Yes.
And see on this side, the difference, the simple difference, how we achieved by just means of, by just doing this high deviation correction. Can you see this high deviation?
Yes.
The moment high deviation is corrected, the cavity opened up and the whole scenario changed. Uncorrected high deviation, many a time we have seen, we have a lot of failure patients come, revision cases come. Uncorrected high deviation can, a simple solution, simple problem can be a reason for the overall treatment failure. So,
Incorrect deviation of the lateral wall.
yeah, so incomplete correction of the high deviation, what I'm trying to say. This high deviation, once corrected, see the middle turbinate is pushed close to the septum and see the cavity opened up. Can you see? So, in order to make this, treatment, topical treatment effective, the state of the cavity is very, very important. And this is the solution what we use, as I told you, the budesonide nasal irrigations. Simple. 0.5 milligram per day, that too topical. Any other question?
Is there any question? Dr. Satish, I think there are no more questions. And on behalf of the organizing committee and on behalf of everyone from Pakistan who are related to ENT, I am really grateful to you for enlightening us with an excellent surgical demonstration and opening new horizons for us in the surgical management of the nasal polyps. And we hope that we will keep on learning from you in the future as well. Thank you very much again. As said rightly by Dr. Sarfraz, that you are virtual guru for many of us. We have learned a lot already from your YouTube videos, and we hope to see you in the future as well. Thank you very much again.
Thank you, sir. Thank you so much for your attention, for your love and affection. And I am very much attached to all of you from my heart. Thank you very much once again.
Thank you. Khuda Hafiz.
Bye.
I hope कि आप सबको इस सेशन was useful. कोई सुन ही नहीं रहा. अच्छा, अब next 10 minutes में food will be served, फिर नमाज होगी और फिर we will